I'm now going to turn it over to Robert Shaw to discuss his paper, Using Data to Manage State and Local Level Mental Health Crisis Services. Robert, please go ahead.
Good afternoon and good morning. There we go. My name is Robert Shaw. I am a Senior Research Associate at NRI. Next slide, please. My co-presenters today, who are also from Colorado, which is accidental, I suppose, are in the order that they're going to be speaking. Mary Hoefler, who's the Manager of Crisis Services at the Colorado Department of Human Services, Office of Behavioral Health. Jenn Conrad, who is Director of Clinical Services at Signal Behavioral Health Network in Colorado, and Tim Gruzeski, who is Transitional and Acute Care Evaluation Supervisor for Data and Evaluation at the Colorado Department of Human Services, Office of Behavioral Health. Next slide, please. So we all use data in our lives to inform our decisions. I see that there's a difference between managing something and operating something. Collecting data does not necessarily mean that data will be used to manage something like crisis services, because managing is the collection and use of data to make decisions about how, when, and where crisis services are provided. Operating, however, is the rote provision of services based more on past activities than reactive to experience. An example of how we use data is several weeks ago, I was with my family in Italy, where it rained every day except for one on our vacation. And on one of the days, the weather report said that there was a 40% chance of rain between 3 and 5 p.m. I took that to mean that I should be prepared and brought an umbrella and a raincoat. My teenage son, on the other hand, interpreted the data differently. His interpretation was that it was not likely to rain, and so he brought neither an umbrella nor a raincoat. It did rain, and so I had to lend him my umbrella. Next slide, please. Thank you. Now, in preparation for this paper, I talked to a number of states and local programs to understand better how they were using data to manage crisis services. I asked them first what to describe their crisis service continuum, then how are data used to inform call centers, mobile crisis teams, less than 24-hour crisis receiving stabilization centers, greater than 24-hour crisis residential facilities, other crisis service programs, and their crisis service workforce. Next slide, please. I also looked at the data that is either being collected or proposed to be collected by the crisis service registries that are in existence in a number of states and or are being developed. And out of that, I found that that the states with the crisis service registries are intending to use them intending to use data collected by them to make services easier to access, to make services more available, to improve outcomes for people accessing services, and for improving the operation of the registry and the service provision system. And when I was doing this, collecting this data, I thought about Domino's Pizza, which describes itself as less a pizza delivery company and more as a technology company. They use data to manage all aspects of what they do, and their bare similarity with crisis services is that they have a multitude of locations. They have customers that they're having to serve. They use their data to manage all aspects. For example, where to locate a franchise, what services, what specials to offer them, and all in the goal of obviously increasing profits, but by increasing profits by as best they can providing what their customers want. And the states and the local programs who are providing crisis services have a similar goal in that they are trying to serve the needs of their communities, really the entire state. Next slide, please. Managing is an iterative and Sisyphean process. Sisyphean because it really is something without end. It requires a constant collection of data and knowledge that can be used to assess all aspects of a provider's or a state's crisis service activities. The prior paper is an example of that, in that states are needing to collect data to inform their provision of services to communities of color. Great efforts are also expended by states to collect data, but it often documents that funding has been well spent and it's not necessarily useful for making management decisions. So states should think about that they should also orient their data collection to making certain that managers have data that is useful to manage their activities. Next slide, please. States and everyone does not operate in an environment where they have the best of all possible data. States and the providers do not operate in that, and they do not always have all the data that they can use, and they cannot always be certain that the data they have is accurate, and they're often certain that the data that they have is not timely. But even suboptimal data is valuable and can provide insight, albeit a broad insight rather than a minute insight. And when those are all that a provider or state has, management decisions can still be made, and if necessary, later unmade if subsequent data indicate that a wrong turn has been taken. It is the duty of states and providers to attempt to provide services as best can be given, whatever environment they operate in. Next slide, please. My co-presenters from Colorado, beginning with Mary Hoefler, will illustrate my point and show how Colorado is using data to manage crisis services. But I'd also like to thank all the states and all local providers who provide crisis services. It's a difficult undertaking. I'd also like to thank the states and local programs that were gracious enough to take time out to let me interview them, including Delaware, Georgia. Within Georgia, there are Southwest and East Central regions, Utah, Washington, and within Washington, the Thurston-Mason Behavioral Health Services region. That is my last slide, and I will turn it over to Mary Hoefler.
Mary, please unmute. Thank you.
I was on mute. There you go. As Robert said, my name is Mary Hoefler, and I'm the other half of Megan Lee from the state of Colorado. And I'm just going to give, I know I'm limited for 5 minutes, and I'm very aware of that, so I talk quickly. So again, if there's any questions, shove them in chat and we will get them later. But for those of you that don't know about what Colorado is doing, is that back in 2014, we started a statewide crisis response system, which included an expansion of mobile services, much more community-based mobile, as well as crisis stabilization beds, so community beds. We have walk-in centers that are 24/7, as well as some crisis respite services that we are still trying to figure out. And also a 24/7 statewide crisis line, which added text. So we have a hotline, a support line, which is a warm line and peer managed. And then they added text back in 2016. I think the challenge for Colorado from the initial legislation is sort of how to be everything to everyone, everywhere, 24/7, all for under $23 million. And certainly the budget has increased. I want to say we're sitting at somewhere between $33 and $35 million. it just is not a lot of money to really provide the kind of timely and kind of response that we would really love to get, but that's what we have. So in the first 5 years, we had an initial 5-year contract with crisis service organizations that were then required to subcontract with providers to provide all the boots on the ground services. And we were very much under a time crunch. So getting the contracts done and getting services up and about, I mean, it was 90 days for each process. It was crazy time pressured. And so we learned from our mistakes, especially around data markers. And so I'm going to talk a little bit just about what we asked for in the first 5 years and how that's evolved to sort of present day, and now being contracted with administrative service organizations and asking for some different data markers. So initially we wanted to understand timeliness, right? Responding to people in crisis and being on time or timely was super important. So with mobile, for example, we still ask that in an urban area, mobile response folks are there within an hour or less. And in our rural and frontier areas, which is really the majority of the state, and just to give you some perspective, we have 64 counties. I always say sort of all but 10 are really rural and frontier, maybe with some booming hotspot like Grand Junction in the midst of a rural county, right? So most of our services are really in the greater kind of rural and frontier areas, which creates its own issues around, of course, workforce, broadband, and things like that. And even getting there within 2 hours sometimes when you consider terrain, mountain passes, weather, all that kind of stuff. So timeliness is still something that we always want to track. The other, we ask for things like, does an individual engage in service planning? Not helpful at all. Like that was an initial ask. We also tracked outcomes, which we still want to track. So things like, was there a critical incident involved in any kind of crisis services? Was there a first responder contact? Does someone get referred to an emergency department? Was there an admission to a higher level of care, like a locked psychiatric hospital bed, or a crisis stabilization unit, which is up to 5 days. People can be voluntary or also they're in a mental health hold. What we've learned through the years is that most of our contacts with people in crisis at a walk-in center go home. They go home with a safety plan and likely some sort of referral versus a resource, right? We want people to get connected. Here, handing someone a piece of paper saying, hey, call this local provider, we know that they don't. And even when there is an appointment made, you know, how do we get people to keep those appointments to stay connected? We also had a category called other in the first 5 years, which we still have. And personally, other is kind of a nightmare because other can mean lots of things. So if we really want to paint the picture of what outcomes are, what is happening when somebody is involved in some aspect of crisis service, the idea of other, it's really difficult. And the other continues to be in present day as well. We look at the turnover of staff and having to retrain people on what is accurate data. What do these data markers actually mean? So other continues to be unpacked even in this next iteration, these next 5 years. We are, by the way, in year 2 of this next 5-year chunk. We re-RFP'd in those first 5 years. And so we're in year 2 of this next 5. The other thing that we looked at was a decrease in suicide risk. So somebody that is coming in to contact with crisis services, whether at a walk-in center or via a mobile response, the problem was in the first 5 years, we had no standardized measure. So some providers wrote narratives about risk decrease. Other providers might have used their own version of some sort of a scale. So we learned very quickly that we needed some sort of a standardized measure, and eventually had all providers use the Columbia Suicide Severity Rating Scale. We also were tracking something that we found extremely not helpful, which was customer satisfaction. So you will meet Tim after Jenn, who will talk about some other data markers, but what we know with customer satisfaction, if you're brought in via law enforcement on a mental health hold, most people are not overly joyed with that. And especially if that hold is maintained and that individual might end up in a bed-based service, whether it's a crisis stabilization bed, a community bed, or even a locked hospital. So asking someone, are you happy with our services? Did we do a good job? Not really helpful. It never guided future planning or impacted what we were going to try to do differently. So that's what I want to say about customer satisfaction. And maybe there's a better way to do it, but how we did it, not meaningful, not very helpful. So we've always asked for timely and accurate data from the very beginning, and that is challenging sometimes. Even in these next 5 years, what we've seen is that because of turnover, because of how things are defined or how an individual clinician might see a certain data ask, is accuracy in data continues to be a challenge. The other thing to keep in mind in Colorado, we have lots of different EHRs. So providers typically have their own EHR. And so they are asked then to submit timely and accurate data to the administrative service organizations. And then those ASOs, those organizations submit them to the state. So we continue to struggle with that. Right now, we do not have a centralized data system where all crisis providers could access information about someone. Even our statewide crisis line, our 844 number, which eventually will be 988, there's not really a centralized data system to help guide interventions. So we're working on that. So processes still feel very siloed, and the state data system that was going to happen a few years ago ended up did not happen because of some vendor challenges. So now we are back in the process of trying to figure out what sort of centralized data system can be really helpful in guiding program and processes for crisis. So in these next 5 years, what we have carried over is the total number of services. What we know is the legislature, other organizations always want to know how many people are we serving. They want to know how old these people are. They want to know their gender. We also have special populations that we've targeted. So people with intellectual and developmental disabilities is a special population, as well as vets. We also carried over, is this a new client, or is this somebody that keeps showing up in crisis? Which, if somebody's there every couple of weeks or within 30 days or 60 days or 90 days, what are we really missing from a crisis intervention perspective? Like, why does this person keep circling into crisis? What are we missing? We're not getting them connected. What are they needing? We also continue to track outcome, which is very important, as well as if somebody goes to the emergency department. Here in Colorado, we don't have a lot of field clearance, meaning that maybe is there a way for EMS to medically clear? I hate that word, and hence my air quotes, my fingers. We want someone to be able to go maybe to a bed-based service or a higher level of care without having to go through the emergency department. We know that experience is super traumatic, especially when we're looking at children and youth who need some sort of a bed-based service or higher intervention for stabilization. So we're trying to understand emergency department referrals. So what's new is that I want to say it was 2 years ago, and maybe actually this current contract year, is we're asking that every individual that touches crisis service gets a follow-up within 24 hours. The only individuals that do not get there are those that get referred to a bed-based service, community bed through crisis stabilization, or a locked psychiatric bed. We are also wanting to understand how often law enforcement initiates a mental health hold. The mobile piece is interesting because these 5 years, there's been a huge emphasis on mobile, like less brick and mortar stuff, but can we get to where the individual or where the family is in crisis? So we want to understand when 844, so our statewide number, when they initiate a mobile request, where is that request going? Is it going to the home? Is it going to jail? Is it going to school? Is it going to an emergency department or another mental health center location. Many of our mobile providers continue to be the community-based mental health centers. In some states, they're referred to as mental health authorities. So many of those providers, the CMHCs, have long-term relationships with rural hospitals, for example, or other organizations where they have been the responder for many, many years, well before 2014 when our services kind of kicked in. So we want to know where mobile response is going. We want to know if that response is paired. And when we talk about a paired response in Colorado, we are not talking about a co-response, which is with law enforcement. We have many co-responder programs throughout the state, not only just sort of urban, but many in rural and frontier areas. So that is a law enforcement driven response that is initiated by 911. So when we talk about paired response, we're really talking about a clinical person, as Megan mentioned, right? And maybe paired with a peer specialist, a case manager, a family advocate, certainly can be another master degree person, but not a good use of funds, right? We also want to know when mobile is not dispatched. So that is, and we have now this big portal through our statewide crisis line provider where mobile response teams are required to enter all this information. So we're hoping to learn something from that data collection source.
Hi there, good morning everyone, or good afternoon, I think maybe for some of you. Mary has touched on a lot of really good points, and so I will do my best not to sort of duplicate some of that. But as one of the crisis administrative service organizations, we oversee 10 counties in the state, which are the most populous areas. As we've mentioned, and we're talking about with data, we do receive a variety of different data points. Mary talked about the episodic data that we receive from our crisis providers, which is unfortunately not claims or encounter level data. So there's inherent sort of Scout's honor in what is getting reported to us from our providers, but it is certainly quite helpful in a number of ways, which I'll talk about in a minute. We also receive other elements of information on a daily or monthly basis, depending. Critical incidents, I know were mentioned, and that can really tell us a lot as it relates to a lot of the critical incidents that happen with our providers or in our facilities are completely expected in a crisis continuum. But there are some elements that might come to light, or we can see trends in as it relates to perhaps there are a large number of individuals who are going to the emergency room out of the walk-in centers, which would not be an anticipated outcome at maybe a high sort of level or rate. And that would be an opportunity for us to look into, what type of safety measures were in place. Were there behaviors that were difficult to manage in the walk-in center that required more of a medical restraint type of situation? Could we have done anything differently in the walk-in center to avert that? Are there sort of medical clearance requirements that certain bed-based facilities are requiring that we might want to address with those facilities if it seems more like defensive medicine versus really opening access to care and easing that access and that delivery? We get information around service diversions, so providers that during their 24 hours of being open have to close for a period of time. And what's that for? Is it due to staffing? I know our previous presenters talked about the workforce challenges, which have been around for a while, but COVID certainly has increased those challenges pretty significantly. And how can we help our providers in keeping their doors open and serving those who are in crisis? That might be looking at what grant opportunities are available for sign-on bonuses, for key positions, nursing positions, licensed clinical positions. Are there kind of like stay bonuses, if you will, or compassion pay for those that have been working through the duration of the pandemic and are really kind of burned out, especially with the workforce issues, are there ways that we can support our providers in keeping the doors open? We ask also for information around service denials. So we aren't an insurance company, so there's not an authorization process for services, but we are interested in learning, are there individuals that are getting denied access to care within the crisis continuum, and why? Are there issues that we need to address there? Are there individuals who kind of in a day got denied across the continuum, and how are we as a system of care helping some of the most complex, challenging individuals and working as a community in that way? With the episodic data that we receive, sort of that Scouts Honor information that I was referencing, there's a lot of information there around demographics of folks coming in for care, the outcomes of services that Mary had referenced, and in those outcomes, as well as follow-up. So those who do return to home and community, did they receive those follow-up services and outreach, and that connection to short-term behavioral supports and services? And if not, why? What are those barriers? Are you serving a large homeless community and they don't have access to cell phones? How might we help those individuals? Or what are you already doing in that area? Or are you doing it and your EHR just isn't capturing that and able to report on that? And how do we kind of address that as well? And I think there are a variety of points, like mobile crisis has been a really important way in which we try to sort of avoid unnecessary ER use or 911 response for folks in behavioral health crisis that aren't, at like a public safety level of need or a medical emergency. And if an outcome of mobile crisis results in, say, law enforcement intervention, why is that? Is that because of a secure transportation need? How do we maybe build a system that doesn't rely on 911 for transportation? And how do we build something out differently? Are there relationships that we need to build? I think all of the data pieces, while they may be imperfect, do provide us a really great opportunity not only to look at the direct service delivery, but also to really assess where do we need to build or perhaps rebuild relationships in the community to help with those access points and to help sort of as a relief valve from the ERs and the 911 system. With that, I'm going to pass it off to Tim to talk more as the data nerd of the group.
Thanks, Jen. Yeah, good afternoon, everyone. My name is Tim Gruzeski. I've been doing crisis data for the state of Colorado for the past 3 years. And as Mary and Jen both mentioned, it's generally been a process of refinement. The first 5 years were a good snapshot of what's going on in the state and where we needed more services. We learned an awful lot from that. And we continue to try and use that to inform current trends or follow legislation and best support people who need access to care and so they can utilize the system as they need to. As Mary mentioned, we're certainly trying to do more mobile services, and that's certainly something we're having success with, even despite the reduced ability during COVID-19's pandemic. And so we've been kind of pushing avenues there and trying to help people as much as we can. One of the more recent data examples I can give is that our crisis line saw a 30% increase in volume over the course of the pandemic, and that was coupled with a high turnover rate as they tried to transition to virtual themselves, or people just unfortunately left the workforce. So we were able to help them secure additional funding to try and address that issue, which did ultimately lower the abandonment rate. And that did result in more of those services being captured. So we don't always get to jump in right like that and interact real quickly, but it is very helpful that we can see those kind of trends and react to them. That's generally been what a lot of our process has been, and now we're starting to get to the point where we've refined enough that we can try and actually implement some bigger goals. We have 988 coming down the pipeline with kind of some national efforts and certainly some discussions within the state for co-responder and how crisis can be on the front lines rather than after law enforcement, because that often results in other outcomes too. So we do use that data an awful lot to try and inform internally and to try and meet external needs as well. And I know we're short on time, so that's where I'll wrap it up and hand it back off to Megan or Robert.
Great. Thank you so much. I did want to note Chris Burke's question. He says, I'm curious about the level of support state/agencies receive when they talk about and report on data and the analysis of data. My experience ranges from a clinician who is savvy with data collection to full-time data analysis teams professionals doing the work. Do either of you have a quick answer to that question? And if not, we can work on it offline.
I can take that one real quick. We do have a wide range, both with electronic record systems that can capture things and the people who can pull that information out. And so we end up developing templates with everybody and do our best to do collaboration to try and make sure everybody's supported through that process. But it's one of refinement, so we're continually updating that.
Great. Thank you very, very much.